So let's get on now with this session now about atrial septal interventions, and start with our anatomy, physiology and interventions that we do for atrial septal abnormalities. So let's go through that. So remember that in transthoracic echo, which is where the screening and entry point for most people who have atrial activity, most of these things are found on transthoracic echoes. And so remember that in general, transthoracic echoes are taken from below, so that in tomographic imaging, most images are seen from the feet. And so when you look from below, then you should have in this diagram in your mind for the anatomical relationships of the structures at the base of the heart. This is a fantastic diagram for which I'm very grateful to Aubrey Almeida. This is a surgical teaching diagram which I've inverted and modified slightly for transthoracic. So remember, you've got left, right, non-coronary cusps of the aortic valve. These are your landmarks which help you orientate where you are, obviously. The atrial septum is adjacent to the non-coronary cusp. And so when you are looking in any view, if you see atrial septum, you know you've got non-coronary cusp near you. If you see non-coronary cusp, then you know that you're near atrial septum. The left atrium obviously is in the centre of a transthoracic image like this. The right atrium obviously to the patient's right, but to your left. The left atrial appendage is the farthest opposite thing away from the atrial septum. So you can see that when we look from above, say in the 3D pictures from above the mitral valve, that the thing that's farthest away from the atrial septum will be the left atrial appendage, being the most lateral part of the atrium, of the left atrium, the atrial septum being the most medial part of the left atrium. But let's just turn all this around and think about some more surgical view. So when you look at an atrial septum from a more surgical view, you tend to look obviously from the RA side. And so when you're looking from the right atrial side, this old-fashioned cartoon here, which we've had for years and years, we're able to recreate this cartoon type image now in real-time live 3D TOE. And so I've orientated this picture so that we're looking from the right atrium, we're standing in the right axilla, we're looking from the right atrium, and we put the superior vena cava coming in the top. You can just see the mouth of the SVC there. You've got the inferior vena cava at the bottom. I've got the atrioventricular groove in the right coronary artery, this tubular structure showing through here. The tricuspid valve is anterior, and the posterior wall, or the posterior part of the right atrium is posterior and to the left on this image. Now what we like to do is use this diagram to talk about the various elements of the rim of atrial septal defects, and we'll go through the sorts of defects in a minute, but we use this nomenclature related to the landmarks that are nearby to each portion of the atrial septal defect. So we talk about a SVC part of the rim, an IVC part of the rim, a tricuspid part of the rim, aortic, superior and posterior parts of the rim of these sorts of defects. You should always in your mind have the aorta to the top of the TV or to the anterior of the TV, because the most anterior structure related to the anterior septum. And when we flip around and look from the LA side, now looking from the left atrium, we have a view here where you've got right upper pulmonary vein coming in the top here. You've got the aorta superior and anterior to the atrial septum, and you've got descending aorta out of the heart there, and mitral valve towards the ventricle. There is an indentation of the aortic root into the roof of the left atrium we call torus aorticus, or the bull's head of the aortic root, butting itself into the roof of the left atrium. And in fact, one of the good landmarks that when you're trying to find out where you are is this torus aorticus. So let's have a look at transthoracic and transesophageal views now as per the line diagram. So the 0 degree view it lines up like this. It's obviously through the atrial septal defect. When you have one, it's through the tricuspid valve and mitral valves like this. When you push the probe down into the person, you get a floor of heart. This is a transthoracic version. You're picking up coronary sinus. And when you pull up and go superiorly, you're getting more of a roof of atrium and the top of the atrial septal defect in this plane. Thank you. When we rotate to 60 degrees with the transesophageal or short axis parasternal in the transthoracic, you get a short axis here of the aortic valve with the 3 leaflets, left, right, non. Remember where the non is, there's the atrial septum, and a pretty typical secundum atrial septal defect with flow from left to right as expected. When you go vertical in the 90-degree plane here at a so-called bicaval view, you should pick up SVC. Let me go back. It should pick up SVC, IVC, right atrial appendage, and you should have high volume shunting going from left to right. Okay. Who has an atrial septal defect? Well, it's easy when it's easy. It's easy when you see a big leak, but all of us can tell stories. I can personally tell stories of atrial septal defects that we've missed because they don't show up so well, particularly in big adults. And so how do you know if you've got an atrial septal defect, or how do you know if you've missed an atrial septal defect? Well, typically, if you've got a proper ASD, you've got a proper shunt, and if you've got a proper shunt, then you've got an enlarged right heart. And here's some work we did, Natalie Kelly and our group did years ago, where we had a look at the relative atrial index, the size of the right atrium to the left atrium. Normal humans, their right atrial area is about 0.7 or 0.8 of their left atrial area. So if they're 15 RA areas and they're 20 LA areas, that's 0.75, that's normal. But we looked at a couple of hundred people who had ASDs with big shunts, and we found that virtually universally their RA was bigger than their LA, therefore their RAI, relative atrial index, RA area divided by LA area, would be above 1. And in fact, it was nearly 100% accurate or predictive that if you have an RAI more than 1, you've got either a shunt or some other problem exaggerating the size of the right heart. We also found that when you fix them with an ASD closure device, almost the next day, they had come back to normal. Not the next year, the next day they had come back to normal. So that the enlargement of the right atrium and the right heart, we good? The enlargement of the right atrium and the right heart has very dynamic components to it which are flow related. So let's talk about atrial septal defect types. The famous and common one is the secundum ASD, and that's going to be the rest of this talk, 75% of them. Primum atrial septal defects or atrioventricular canal defects are related to defect of the cushion and associated with mitral valve abnormalities. And sinus venosus and coronary sinus are more rare, but we'll show a picture of a sinus venosus one. The primum one, this is the only shot I'm going to show, is down low, right on the atrioventricular valves, is an abnormality of this whole endocardial cushion, is associated with an ASD and usually cleft of the mitral valve and big shunts. The sinus venosus defects are in the roof of the heart and are quite a different embryologic abnormality. Now, I've tipped this upside down, left to right, and 90 degrees around to try and give you the anatomy here. But basically, superior vena cava, right atrium and left atrium, and the whole roof of the atrium is missing, and there's this mixing of blood at the very top. There's the defect and huge volume. The sinus venosus atrial septal defects are by far the biggest flow of the ASDs, and indeed the one that I missed in for my sins many, many years ago was one of these where you just cannot see these on transthoracic echoes in adults, but it had a big right heart. I should have noted it, but what I fell for, and I've seen before, is that people say, oh dear, they've got pulmonary stenosis. They don't have pulmonary stenosis, but they've got a high velocity through their pulmonary because there's such a ton of blood going through there that they are looking like PS, but they're not pulmonary stenosis at all. They're volume overload on the right heart. So let's go back to secundum atrial septal defects. Typically the hole like this would be, back in the old days, seen in open heart surgery, and the shortest half-life of anything in the world was the time between the echo diagnosis of the atrial septal defect and the cardiac surgeon turning up in your rooms. Usually that was in the order of 30 seconds when they sniffed one of these coming, because they liked doing them back in the day. I think it was a nice operation in healthy young people. And they would put in a bovine pericardial patch, something like this, to close them. And it's a beautiful operation, but it's still an operation. Then came along this thing in 1998, the Amplatzer device, of which there have been thousands and thousands put in, the first of the structural interventions. And this has been the vanguard of this whole industry of structural heart disease intervention. And so these devices here are made of nitinol, of this metal, which spring loads back to its factory-designed shape. You can pull it in and out of that catheter 1,000 times and it will still spring load back, and I can tell you that for sure. I've got one on my desk. I've done that for patients as a teaching tool, and it still spring loads back 10 years later. It's got pads inside it of cloth which basically push through from RA to LA, put one pad out, pull it back onto the septum, deploy the neck, and close the second pad on the outside, and you end up with something that looks like that. And so After we size the hole, and you're going to see this in our case, we size a hole and determine the size in millimetres, something like 20 millimetres. A catheter is put through from the right femoral vein through the hole. The first pad is opened up, pull down onto the septum. There's the first pad in 3D. Pull down onto the septum, and then the neck is opened up here. And then the second pad is opened up, and the device deployed, flattened out, and then let go of. And whilst it's feasible to imagine misadventure with these things, in general they're incredibly safe, they're very effective, and they universally work to relieve the leak. We put them in children. We've been putting them in children now for nearly 20 years, in adults for nearly 20 years, with very low complication rates and high success. So basically, this was the first of the structural interventions that basically worked. "3D imaging has helped us a little bit, although not a lot. Most of this is actually done under 2D guidance. We are able to sometimes with 3D, determine that there are multiple holes or fenestration, and you'll see in the case, we've got one of these, with multiple pieces of jets going through. Now, the problem with this was that this required a general anaesthetic for a transesophageal echo, which some people think is a bad thing. I personally don't. And so ICE has been used, and certainly in our institution, most ASDs are done with ICE now. The ICE allows you to put an echo probe in the right atrium and look up at the atrial septal defect. And this has the advantage of no general anaesthetic. It has the disadvantage that the echo doctor doesn't run the echo, which I think is universally a bad thing, obviously. And it gives you the perspective that you're looking from RA side for the only time ever in imaging that you look from the RA side rather than from the LA side or the apex. So every time you see the pointy bit of the sector, you'll know you're looking from the RA side rather than the LA side. And so, wherever the point of the sector is, you're in RA. So, obviously, aortic valve, looking in short axis. So, we've got a short axis view. The camera has obviously been twisted a little bit. Atrial septal defect, looking into RA. Turn the camera around, look down onto the tricuspid valve and the right ventricle. There is a wire going across the heart. We're so used to seeing them go from this way to this way, from bottom of the screen to the top, because that's typically the layout. But in ICE, it's obviously the other way around. Sizing balloon and deployment, with remember that the first pad is put into the LA just like before, but it's in the far field when you do ICE, and then pull back onto the septum like that and finally deployed. So to summarise, therefore, the atrial septum has been the vanguard of and the leader of structural intervention for macroscopic heart disease. And atrial septal defect closure fundamentally works, and it's one of the places where now, with the greatest respect to our surgeons, there's not a lot of surgery done for secundum atrial septal defects, except for the very biggest ones where the devices really just won't clip on. TOE is the benchmark, and the standard ICE has been used with the pros and cons, as you've seen there. Thank you very much.